per usual. Hi, thank you so much for having us. This is my first time speaking at the symposium after coming for a few years. We love this community. I'm Pam McDonnell. I'm a epileptologist and neurogeneticist at CHOP, and SLC6A1 neurodevelopmental disorder is my clinical interest, and I work a lot with Lena. I'll let her introduce herself.
I'm Lena Lusk. I'm a genetic counselor at CHOP, so I see a lot of the SLC6A1 patients with Pam and have been working a lot on the research with her.
So this is a summary of the poster we are presenting here, and then at AES we'll be there on Sunday. It's called a clinical signature and longitudinal seizure pattern of SLC6A1 related neurodevelopmental disorder. So a mouthful. So just quickly to go over, we're going to briefly discuss SLC6A1. I think pretty much every talk today went over it and the different symptoms. We want to talk about the clinical characteristics of our cohort, the seizures characteristics of our cohort, and that's really what we're going to focus on for this presentation. The anti-seizure medication use and outcomes that we have seen, and then some conclusions and future directions. So as we have said a lot today, SLC6A1 related neurodevelopmental disorder, or NDD, can present with different symptoms. So we see a vast majority of children have early onset epilepsy, which can be seen as early onset absence seizures or just typical absence, and then a myoclonic atonic epilepsy picture, but also just some other mixed seizure types. We see a lot of hypotonia or low muscle tone, and then a variety of neurodevelopmental manifestations, particularly developmental delay, which often presents before the seizures, and we know also speech tends to be the most affected. We also see autism spectrum disorder, autistic traits, as well as a variety of psychiatric disorders, and also that has been highlighted throughout today's discussions, but ADHD, anxiety, sleep disturbances. We see movement disorders. We're starting to see more patients too that are presenting with a movement disorder first rather than seizures, and even just looking at other manifestations outside of the neurological symptoms, such as GI symptoms like constipation, for example. So our goals for today. While seizure onset and types are documented, and we all have talked about that a lot, we don't have a lot of natural history data on the medication response and long-term prognosis, and this is limited. And it's nice to follow all the discussion about gene therapy and need for more information on the natural history of the disorder. The goals today, again, focusing on the SLC6A1 related NDD symptoms. We'll briefly go over those, but really the main goal is to elucidate the natural history of seizures through childhood, and we have some adults in our cohort as well. So we did a longitudinal disease reconstruction by looking at all of our CHOP patients with confirmed SLC6A1 diagnosis that we had at the time of the study. We included all documented clinical diagnosis, developmental milestones, seizure types, frequencies were matched per month, and then the anti-seizure medications as well were mapped per month. And we used phenotypic traits that were standardized using the Human Phenotype Ontology, or HPO. So I'm going to let Lena take over and talk about our results.
All right, so this first slide is just showing a little bit about our cohort itself. We had 33 individuals, 17 were female, 16 were male. The age range was from 1 year to 45 years, with a median age around 8. And all together with all of the patients across all of these years, we had 3,476 patient months of data, or about 290 patient years. So clinical features, as we've kind of talked about, we saw gross motor delay and fine motor delay in about half of the cohort. 93% had a language delay. About 50% had either an autism spectrum diagnosis, or they had autistic-like traits. 58% had either ADHD or similar traits like short attention span, impulsivity, or hyperactivity. 42% had either severe tantrums or frequent tantrums. 30% had aggressive behavior. 45% had sleep disturbances. And then 67%, or 2/3, had seizures. So it's this part, the seizures, that we're going to focus on for the rest of the talk in sort of mapping these out. So just some overall information about seizures in our cohort. The median age of onset was 29 months with a range of 4 to 89 months. 55% of the individuals that had seizures were able to achieve 24 months or more of seizure freedom. And of those individuals that had seizure freedom, the median age at their last seizure was about 7.5 years, with a range of 4 to 12 years. And we had 5 adults in our cohort that had epilepsy, and of those, 3 of them were seizure-free. 2 of them were seizure-free on medication, and 1 was seizure-free without medication. Of the seizure types, there were a lot of different ones, a lot that probably look very familiar. The largest group here would be these atypical absence seizures. I'll note the pie chart is breaking down by all of the seizures experienced in our entire cohort, what % were these different seizure types. So you can see a little less than half of all of the seizures were atypical absence seizures. But when you look by individuals and what seizures they had over their lifetime, 77% of those with seizures had an atypical absence seizure at some point. Similarly then, for myoclonic atonic seizures, the other sort of hallmark seizure type in SLC6A1, 27% of those that had seizures did have one of these, or at least one myoclonic atonic seizure. Next group would be atonic seizures, with about 18% having those, and then typical absence with about 14% having those types of seizures. And then if we take all of this seizure data and we map it out over the lifespan, we can see it kind of charted out here in this alluvial plot, which tries to show the complexity of seizures over time. It's mapped from age 0 to age 10 years on a month-by-month basis. The height of the bars corresponds to the proportion of individuals that were having those types of seizures at that given month of time. And then the color of the bars represents how frequent those seizures were occurring during those months for that individual. So the dark red color is, let me see if I could do my little pointer, is greater than 5 a day, whereas the gray color means that they were seizure-free. So we can see there's sort of this start before age 1, so around 4 months is where it begins. We can see there's sort of a peak of seizures before age 3. And then a gradual tapering down that these older ages, we do still see some seizures, but they're occurring less frequently and in fewer overall individuals. We can break this down a little bit further by looking at the main seizure types. So for the atypical absence seizures, we do see a similar pattern still. You can see it's starting before age 1. There's this sort of peak that occurs before age 3, and then a gradual tapering down over time. We can also look at myoclonic atonic seizures, but I'll note we only had 6 individuals with these seizures in our cohort, and half of them were under age 5. So as we get to older ages, there were too few individuals to map out the data. But we can see a general similar pattern here, even in the myoclonic atonic seizures. Then if we take this data, we can compare to some other genetic epilepsies and see how they might be similar or different over time, and if there's a unique pattern to SLC6A1. So this is the same data from all seizures that we saw in the last slide, but it does end over here at 60 months instead of going all the way to 10 years. And then we can compare to these other genes with the data from McKee et al. 2025 and SYNGAP1, SDXBP1, and SCN2A and SCN8A, just to compare the different patterns across these genes. So you can see they each have a unique pattern in terms of when things are starting, the proportion of individuals over time, whether that's increasing, decreasing, or staying the same. But to kind of highlight, kind of comparing more apples to apples, we can look at just the SYNGAP1 and SLC6A1 because they tend to have more similar seizure types, including those absence seizures. And you can see SLC6A1 is starting earlier and has a more gradual increase and decrease compared to SYNGAP1. So some unique features here to SLC6A1 that can be important to keep in mind as we go into clinical trials and knowing what we would expect before a medication or new drug is added. And finally, I'll talk a little bit about effectiveness of different common anti-seizure medications in our cohort. The 5 most common medications that individuals were on were valproic acid, levetiracetam, lamotrigine, ethosuximide, and clobazam. And if we look at their effectiveness, in these graphs, you can see sort of the gray dots represent like non-significant values. The sort of teal, blue, green dots mean there was a statistically significant change in a positive direction, meaning fewer seizures or maintenance of seizure freedom. And then the red dot was an increase in seizures that was statistically significant. So I'll note that none of these were significant for myoclonic atonic seizures, which we had a much smaller sample size for that particular seizure type. And then there are medications like ethosuximide that are really only meant to be used in absence seizures. So not surprising that it's not effective for myoclonic atonic seizures. But you can see in particular that it's valproic acid and clobazam that had statistically significant improvement in seizures. Valproic acid was 30% more effective compared to all of the other medications used in the cohort in terms of maintaining seizure freedom or reducing seizures. And then clobazam was 40% like more effective compared to all the other medications that were used in the cohort. And with that, I'll turn it back over to Pam.
Great. So in summary, we highlighted that psychiatric diagnoses are common because I know we talked about seizures a lot, but from meeting with all of my patient families and going to the lab meetings, I know that counting seizures is not always the most meaningful thing we want to do. So we hear you, we realize it, and hopefully, with these conferences, we can put our minds together to figure out what are these, markers that we want to look at when we are doing gene therapies and even just repurposing medications and things like that. Seizures in SLC6A1 show a unique longitudinal pattern, and it's dynamic. It's not like it comes on strong and just stays the same. As we have seen, we have not as an early onset as some of the channelopathies, right after birth, although, these days we can see anything. But in general, we're seeing them first year of life, less likely than just the toddler years, and then some drug resistance initially, but often many of the patients end up becoming drug seizure free in elementary school years and many in their high school years, and then as adults being able to either come off medications, or the two patients that we listed that remain seizure free on medications actually had been seizure free for many, many, many years, and they had not taken off the medication because of fear of recurrence and some abnormal EEGs. And I think as we, at least the clinicians know, valproic acid and clobazam, no surprise there. I'm always very mad at valproic acid because we have not been able to make a better medication for like any seizure since then, and it has a lot of side effects, as I'm sure the families know. But this lamotrigine less clear effect, which made me sad, but this isn't only in our cohort, of course, so we continue to collaborate and pull our patients together and really hopefully be able to take a look at larger numbers. And then, of course, as we move forward, learn more about other seizure medications that we could potentially use. And so really our next steps here is what we've all been talking about today. We want to leverage our data set we have. We have a large data set of patients we follow. It's growing every day. I want to thank everyone in this room because I think that is part of what you're doing, telling new families, advertising, everything. So that is so wonderful. And we are already able to do standardized measures. We have PTOT in our clinic. We're tracking over time. We are trying to figure out how to better assess cognitive ability, motor functions, and psychiatric features other than just what's being documented in the chart, but that's how we're doing it now. We have QEEG data available and capabilities of doing more, and then we are just starting to figure out how to collaborate with the Brain Gene Registry project, so that more to come. Not a lot of details there, but that's about all we have. We want to thank everyone. Sam Miller, our genetic counseling thesis student who really started the project, and Michael Kaufman and Jill McKee, who were key. Michael does all our data analysis, so he's wonderful. Dr. McKee inspired and helped us a lot with this project. And of course, Dr. Helbig, the Engine Lab, they assist with everything. Our team engines are Epilepsy Neurogenetics Initiative clinic, so there we see all the patients. And all my colleagues always remember to refer to us, even if they do a new diagnosis, they know to send them to me after. And of course, most importantly, our patients and our families for everything you do and for letting us take care of you. It's such an honor. Thank you.